Hi, Prof. Rangers.
So hi, how are you? Sorry, I'm just fiddling with my mic.
All good. How are you doing?
I'm very well, thanks. Just gonna quickly take my picture and see if it works. Yeah, there we go.
Yeah, perfect.
Right,
And
great,
why not? You can see my face.
good.
Nice to meet you, actually.
Yeah,
Would you
it's
like
nice.
to, would you like to test the intro slides?
So test the.
The introductory slides.
Yes, yeah, certainly, yeah.
Okay, cool.
Oh, I'm not sure if I'm supposed to be seeing any slides. It just said blood assay found.
I can share them. Give me one sec.
Oh, so from my side, must I share the slides? Is that what you're saying?
Either way, I mean, I'm happy to share them. I've got them here.
Okay. But if you share them, I won't be able to advance them, will I?
I can give you control and then you can advance them.
Oh, okay, that's great. Yeah.
Okay, cool. And then I'll just let you test. There you go. It should work now.
So those are the wrong slides, though. This is confronting aggressive cutaneous T-cell lymphoma.
I'm just testing you.
Oh, right. Sorry.
No, I'm not. It's a mistake. Thank you so much. Um, yeah. Okay. Do you want to see if you can advance them?
Yeah. So I can see the slides and then I just advance them like
There we
this.
go. Perfect.
Perfect. Yeah, that's easy.
Okay, great.
So essentially, I just go through these slides as an introduction, introduce Dr. Shaheen, and
That's
then
right.
give the floor to her.
That's right. Yeah.
Okay, perfect.
Awesome.
Right. So now we're just waiting. And if I understand correctly, we must just hold on until we've got at least 30 people online.
Yeah, that's right.
Okay, perfect.
So I'm gonna play the intro video in the meantime.
Okay, that's great. Thank you.
Awesome. Thanks.
Hi, good afternoon, everyone. I see it's 4 o'clock. I think maybe if we can just wait for 1 or 2 minutes to see if anyone else will join.
Hello. تعملها سكرين كبير.
جربي. لكن
دي ايه يا كريم؟ دي ايه؟ دي ايه؟
هم they can see you لا أول سنة.
اه.
But we they can hear you. So can you hear us well?
Yes, we can hear you very well.
شكرا لا يا كريم.
Good afternoon,
Yes,
Dr.
they can hear
Shaheen.
you.
You can?
Yeah.
Slides control can.
Hello.
Hello.
نفس الصوت.
Okay. Yeah, we can see you well and we can hear you well.
Perhaps we can start the introduction, Sir Longan.
Yes, yeah, I was thinking that. Just to be sure, Dr. Shaheen, are you ready to proceed? Well, in the meantime, let's go through the introductions. The title of today's talk is The Importance of Patient Data Collection and Innovative Molecular in a Resource-Constrained Environment, which I think is very topical for the South African setting at the moment. So again, just a thank you to the management team for setting up this meeting.
بتاعتنا فين؟
هذيك هم تجيب ده يبقى زي they can see.
Just a reminder
Hello.
that this meeting will be recorded, and you are able to access these recordings going onto the website. CPD points are available. Obviously, you just need to enter your information correctly and not be on a shared group. And unfortunately, need to spend at least an hour online to get your points. There's a mailing list, which you can scan in using the QR code to get access or to get further details on this. So the agenda for today is we're going to be receiving a talk from Dr. Shaheen, followed by a short period of questions and answers, and then we will close. I think while we're waiting for Dr. Shaheen to get ready,
هقول من
before I
هنا
do the
بقى.
formal
هقول
introduction.
من هنا.
Hello.
Hello, thanks very much for sharing with you this presentation about the story of prophylaxis in Egypt.
So, sorry, Doctor, can I just interrupt you for 1 second? I just want to formally introduce you to the group. So we'll be with you in a minute. I just wanted to welcome Dr. Shaheen, who is a leading Egyptian pediatric hematologist and is renowned for her work in improving care of children with hemophilia and other bleeding disorders. She serves as a consultant pediatric hematologist at the Missouri Children's Hospital and is the medical supervisor of the Hemophilia Center of Excellence and Rare Bleeding Disorders. She also consults for military hospitals and health insurance organizations. By so doing, contributing to the national policy as part of the advisory board for the pediatric hematology guidelines. Dr. Shaheen holds several key national roles. She's a member of the Pediatric Hematology Board of Egyptian Healthcare Authority, a trainer and examiner for the Egyptian Board of Pediatrics, and advisor to the Egyptian Health Council. He has co-authored Management of Hemophilia in Egypt in 2018, which has aligned the national standards with the international best practices. Her work has significantly improved diagnosis access to clotting factors and multidisciplinary care across Egypt. Internationally, Dr. Shaheen has contributed to the REACH program, helping to establish hemophilia treatment centers and health training care centers in Egypt. Her research focused on hemophilia, sickle cell disease, and thalassemia, as well as health system strengthening, with publications in Hemophilia, Annals of Haematology, QJM, Medical Journal of Cairo University. She's especially interested in cost-effective care, diagnosing equity, and personalized medicine in the pediatric hematology department. So welcome this afternoon, Dr. Shaheen, and we're looking forward to hearing your talk.
Any presentation?
Can you see the screen now, guys?
Yes, we can. Thank you very much.
Starting our journey to reach the top of the pyramid. This is my disclaimer. Egypt considered a very, very big country with ancient Egyptian medicine and combining with the modern society. Amazing issue pushing us to develop a new pyramid of hemophilia management. Egypt, one of the country with hemophilia A patient, one of the biggest country in hemophilia A patient across the world, and according to estimate of the world hemophilia, the number of our patient more than 6,000, hemophilia A more than 5,000, and the hemophilia A with active inhibitor more than 400 patients. This is the demographic distribution of our patient in a very big country for more than 100,000 of people. Regarding this demographic, we know that 50% of our patient is under 18 years, which is covered by the health insurance organization. A very big number, more than 2,000 of patients with hemophilia A. Egypt considered the 7 highest in hemophilia regarding the world. And the estimated, there is a difference still, there is a gap between the estimated number and the actual number, which implies a big effort for the country to enhance budget, to enhance distribution, to enhance the gap between the estimated number and the actual number of hemophilia. Regarding the hemophilia care in our country, it started in 1960 with the Egyptian Society of Hemophilia, and the Egyptian Society of Hemophilia in our country joined the World Federation of Hemophilia in 1971. And through the years, we empower our engagement with the World Federation of Hemophilia. Regarding the health system in Egypt, 3 systems, the health insurance organization, dealing with the children and the student up to 18 years, the adult working and insured by several companies or private insurance. This cover more than 70 million Egyptians. Regarding the Ministry of Health, dealing with the patient above 18 years. But we have the universal health insurance, which will cover all the patients in the next 20 years, but now implemented in some government like Luxor, Port Said, and Suez. How to build, how to change the pyramids of hemophilia management, we have step by step to improve the quality of management. Regarding the identification, starting by identification to improve any disease, you should to identify the burden and your challenge in hemophilia, raising the awareness and preparing the whole system, the whole health system to value-based type of management and to record the outcome measure. Regarding identification, the burden and the challenge in hemophilia, like hemophilia, life equal bleeding, life equal pain, life mean a prison. Social and family burden, due to increased consanguinity in Egypt, we have a lot of social and family burden with the inheritance pattern, all the family coming to the hospital many days per week. Regarding the landscape, through the years, we improve our safety and the efficacy of our treatment. Starting in the early 1997 by cryo and the plasma, up till now, we advance the treatment option up to the non-factor replacement, passing by the plasma-derived and the recombinant factor. Mainly in the past, our management of hemophilia on-demand treatment, very few patients on prophylaxis, very few patients. What is the result of this? What is the result of this treatment? More hospitalization, more life-threatening bleeding, more intracranial hemorrhage, more intra-abdominal hemorrhage, more burden in the multidisciplinary every day. In our ER, the hospital, we have more than 30 patients with intracranial hemorrhage, intra-abdominal, life-threatening, which burden in the whole medical system, not the hematologist. The hematologist, the blood banker, the surgery, the ER staff, very huge burden clinically. So very bad quality of life. Regarding the disabilities, more than 60% disabilities, missed school per day, developed inhibitor 20 to 20% of our patients. By this method of treatment, the annual bleeding rate more than 60 days, in some patients more than 100 days, and the hospital admission 7,000 per the patient, more than 2.2 night per every patient. So very bad quality of life, and many studies in Egypt, very, very bad quality of life. At this point, we identifying our challenge. We should identify the challenge like every country, the silent battle and the struggle of the hemophilia patient, the annual bleeding rate and the clinical burden, the absence of the hemophilia center, incapability of the health system, and the lack proper diagnosis and dealing with the hemophilia patient. At this point, we start to realize we have a lot of a challenge. Loss of a generation, a tragedy of life of hemophilia, we should be solved. Our challenge, patient adherence, the availability of the treatment, the difficult, the cost, a lot of a challenge, and we should facing this challenge. To face this challenge, starting by raising the awareness not for the health system, but the awareness for the patient, for the family, for the health authority, community-based awareness, and every change is starting by education and awareness. This by a different campaign, training program. We visit more than 10 governments to teach the patient, the family, the health staff, the physician, the whole team, the dental, the physiotherapist, the pharmacist. And in every visit, we have a record for the quality of improvement of awareness, not through the program, but also through the social media. We have a lot of TV program, regular activities, and videos through the TV. Raising the awareness of the patient and the family play an important role. We have a lot of patient educator and patient psychiatric and patient social worker, increasing the awareness and of the patient and the families, how to deal with the patient as a person, not as a diseased child, as a person in the community, not as disease case. Starting by collaboration and starting by shared decision making. the multi-stakeholder collaboration, including to achieve national adoption and a long-term commitment. We have a collaboration between the stakeholder, the payer, the health practitioner, and the patient themselves and the patient organization. This will enhance the outcome, enhance our strategy, enhance the protocol, enhance the budget implementation. This the shared decision making to keep the patient in your heart, to keep the patient-centered care. The HIO manager, the hospital manager, the patient through the advocacy of the patient and the society, the finance, the IT, even the training and education part of our organization. This building of team, not only this, but inside the hospital, you have a teaching the team, the whole team, the surgeon, the dental, the blood banker, inside the hospital team, and to be a rule for every caring health professional. What is his role? Expanding the service, not for hemophilia, but also for von Willebrand disease. If each of the team know what is his role, documented role, the result and the outcome will be better. The collaboration, not inside the organization, the communication of the different part in our organization, the hospital, but externally with the World Federation of Hemophilia and the health insurance. We have a lot of meeting, we have a lot of collaboration for implementation of guidelines, for advancement of the hemophilia center, for education of the hematologist and the physician and also fiduciary. We have a lot of training, we have a lot of meeting with the World Federation of Hemophilia. To advance your treatment, you should to have a national guideline, and you should to advance and update this national guidelines for the standard of care, to be a standard of care across the country, to be implement this guideline and recommendation, and this to help the patient and family informed decision in the management. You have to educate our patient according to the availability of treatment and the drugs, what is available, the side effect of every drug, and what is the positive and the negative for each drug. Implementation of this guideline periodically upgraded for the standard of care. This is the first edition of the Egyptian guideline, and we updated by the second edition of the Egyptian guideline. To empower the path of hemophilia and to reach the value-based issue, you should to have a powerful hemophilia community. In Egypt, the Egyptian Society of Hemophilia have a very powerful role. This role by education and awareness campaign for the raising the voice of the patient, and through videos, through program, continuous medication, through a website, to enhance the voice of the patient. You have to understand the need of the patient, the mind of the patient, what they need, what they want, and how to understand their expectation of life. After that, how to prepare the whole system to creating a value-based health care, how to convince the health authority that hemophilia and the new novel therapy of hemophilia is a health priority. So should we have a statistic including prevalence, the mortality, the remission? We should have guidelines including the clinical burden and the economic burden. We should have what available of treatment. We should to be clear with the health authority. What about the treatment, the positive and the negative treatment of every type of treatment, even the novel therapy. We should to be ready for asking and argument with the health authority. We should to know what is the different type of treatment and the cost-effective treatment with the public health cost analysis. Number one, to change the treatment concept from the old of infusing hemophilia to decrease the bleeding to the new concept that changing the life of the patient to be equal the normal non-hemophilic individual. So shifting the health system from fee-for-service payment to outcome service. That is mean the value of the patient and the value of everyone. To change this way of thinking, we should have data and we should have statistic. In our organization of the health insurance, we have a governmental registry. In collaboration with the Egyptian Society of Hemophilia, we count every patient in every area and the demographic distribution of the patient, the weight of the patient, the type of inhibitor, the joint status, what is the target joint, to put a strategy for implementation of this prophylaxis. What about the cost of illness study? How to implement a cost of illness and the budget impact model, confirming the introduction of a novel therapy, comparing the novel therapy by the other therapy or the past therapy. We have a lot of cost of illness study, starting in our hospital, in Masri Children's Hospital, comparing the direct medical cost and the indirect medical cost in some patients with the treatment of on-demand treatment and the prophylaxis treatment. Concerning the consultation visit, the diagnosis and the lab investigation, the on-demand treatment management, treatment hospitalization cost, and the surgery cost. Before implementation of any strategy, you have, and also convincing the health authority, you have a disease management file. This disease management file and the objective including the epidemiology, the clinical burden, the national cost of the illness, the international guideline, and how to improve and implement this cost-effective study by systemic review, economic evaluation of each type of medication and the cost of illness, and what about the guideline and management approach in our country. The first study done before implementing the prophylaxis, including 100 pediatric patients, 250 with inhibitor and 75 without inhibitor. And the second study, including also the adult patient, we see that the total budget impact saving more than 60% in the payer budget versus on demand regarding the hospitalization, the diagnostic tool, the rehabilitation, and the hospital day. At this point, we should to change our prophylaxis protocol. After data, after preparing the mind, after updating the guideline, we should to implement the new prophylaxis of treatment. In collaboration with the health insurance staff, professor from also with professors with different university, the Egyptian Society of Hemophilia, we implemented the high expert panel of hemophilia for optimal healthcare service, utilization and removal of the barrier, effectiveness of each therapy by the cost-effective, reviewing the guideline. We review all the guideline, the World Federation guideline, the Egyptian guideline, and the Gulf guideline. What is our clinical practice and what is the type of our patient and the type of management to implement a new prophylaxis protocol and the method of implementation and sustainability of this drug. For non-factor replacement, we always use the factor replacement, whatever the plasma-derived factor or the recombinant factor. But 2019, we start to launch the emicizumab. In 2021, we have phases for implementation of this drug. This is the first phase, the first phase, including a small number of patients. And when you implement a new drug, you should to have a criteria of inclusion, and you should to divide the patient to a sector to implement a new drug. This, the first phase, including the hemophilia A with positive inhibitor, the small age, early stage of arthropathy, and including more than 300 patients. The second phase, more and more expansion of our treatment for hemophilia A with inhibitor and without inhibitor, with the life-threatening and no limitation of the age. So this includes more than 500 patients. In April 2023, according to the ministerial decree, the Minister of Health declared about the prophylaxis for all hemophilia patients. And this led to a nationwide commitment to prophylaxis, making a pivotal moment driven by patient need and expert insight, the voice of the patient, what they need, what their hopes. So we start the third implementation phase of the prophylaxis, including all the hemophilic patient, inhibitor and without inhibitor, fact by factor or non-factor, with a criteria. So we update our guidelines. Factor 8 prophylaxis for the late secondary and the stage of arthropathy, secondary prophylaxis and tertiary prophylaxis, the non-factor, the positive inhibitor, the primary prophylaxis, the early stage of arthropathy, the cerebral life-threatening bleeding. How to make through this process of implementation? Structure, the process, and the outcome. Structure, we expand our hemophilia center and the health insurance up to 27 central infusion clinic and management and follow-up, beside the Ministry of Health, the Blood Banker Center of Hemophilia. In our hospital, this is the Hemophilia Center of Excellence. This is the only Hemophilia Center of Excellence all over Egypt, with a multidisciplinary team, including a surgeon, the social, the patient educator, the hematologist, the dental, all the branches requiring for dealing with the hemophilia patient. And this photo, 1 month ago, the Minister of Health visit our center and talk with every patient and listening to the story of every patient to be convinced with the implementation of the prophylaxis and real stories about the outcome of the prophylaxis protocol. How to implement this prophylaxis? Through a higher committee. We examine every patient, and every patient have a report recording the joint status, the inhibitor status, and also hemophilia B and von Willebrand. And we visit many countries and the government and the hospital to examine patient by patient. After examination or after assessment of each patient, which type of prophylaxis, non-factor prophylaxis or factor prophylaxis, according to the criteria in the updated guidelines. By the non-factor, very easy infusion process according to the protocol, subcutaneous, and our patient loading dose 3 milligram per kg per week for 4 weeks, maintenance dose 3 milligram per kg for 2 weeks, but we have more than 75 patients, 6 milligram per kg per month, which is very documented, easy, regulated infusion process. In October 2024, we reached more than 1,000 patients on non-factor replacement and equal more than 1,000 patients on non-factor replacement. But now, the last month, up to the last month, more than 2,200 patients. So the per capita increasing from 0.2, 0.3, 0.6, 0.7, 0.8 up to 1.1 in 2023 and 2024. Through this journey, through struggling of this journey, we update our process through introducing the Egyptian National Registry, understanding the disease burden, introducing hemophilia center and expansion, empowering and the health professional with enhanced training for the multidisciplinary team, and ensure precise diagnosis and the lab monitoring, and listening to the voice of the patient and the method of the patient. We shift to more than 80% of the Egyptian hemophilia patient on prophylaxis, and a small number, the moderate type or mild type, not covered by the prophylaxis. How to build a culture of adherence and continuous improvement. Adherence, how to build the adherence. You should to have a patient educator. We have a big rule. This patient educator discuss the treatment method and the importance of this treatment and the negative and positive effect of this treatment, how to deal with the lifestyle. With the stakeholder, we have a standardized approach to sustain this protocol and this continuous education for how to implement the protocol. In every infusion center and in every hospital, we have a patient educator meeting and interview with the patient and their family. But this is not for outcome. What is the outcome? The outcome, not only the annual bleeding rate. In every country, we should have the outcome for satisfaction and justification of our protocol, for upgrading the guideline, for convincing the health authority that this treatment, novel treatment, is very effective. We should have idea and the criteria of outcome. Prophylaxis becoming a standard of care through the Egyptian healthier generation. What is the outcome? In our hospital in 2024, the annual bleeding rate before prophylaxis, more than I said, more than 100 days, now 1-2 per patient, mainly post-traumatic. The hospital admission, 90% reduction on the hospital admission. The joint assessment score decreasing to improving to 1-2. The physical activity before prophylaxis, no physical activity. Now, most of our patients collaborate and engagement in swimming, playing football, and game sport. The safe surgical outcome, excellent hemostasis. As we see in the first slide, the circumcision is starting at the ancient Egypt surgery. So circumcision consider a belief of religion, purity, clearness for every patient. Every patient requires circumcision after starting the treatment. So the surgical outcome regarding the circumcision and the whole big, major, minor surgical procedure, very excellent hemostasis, except one for dental. Most of our patients, 90%, up to 100, very adherent to the treatment. This related to the patient educator, school attendance, 75% regular school attendance, and self-care more than 80%. Regarding the global impression, most of our patients very much improved, very much improved. And the EQ 5D, 5L score, most of our patients very much improved regarding the mobility, the self-care, the usual activity, the pain, and anxiety. In a very recent study done in 2025, we have also a study by interview of most of our patients, comparing the on-demand treatment and the treatment before prophylaxis and after prophylaxis. As we see, like the other study, that most of the patient after starting prophylaxis, the bleeding rate less. Regarding the Emicizumab, the bleeding rate and the hospitalization decreasing up to 0.17 regarding the factor 8.5 per 6 months. Also in this demographic and this statistical analysis, we see that the patient on emicizumab 97% more mobile, more active, more physical activity regarding the prophylaxis by factor 8, 20 to 25. Difficult in walking, the patient after starting non-factor replacement can walk more than 10 minutes and can descending the stair. This is in our hospital, but we have also a study for the different center affiliated to the health insurance in 2022. This study showed comparing the on-demand treatment with the patient with factor 8 prophylaxis and novel therapy prophylaxis, non-factor prophylaxis, the annual bleeding rate decreasing in the novel treatment non-factor to up 1-2 per year, percentage of the spontaneous bleeding, most in the on-demand and most on factor 8 prophylaxis, but 5% most of the bleeding in the non-factor post-traumatic bleeding or post-accident bleeding. The zero bleeding in the factor 8, 35% of our patient, but more than 83% of the patient on the non-factor with a zero bleeding. Regarding the target joint, as we said before, the target joint and the health joint score improving dramatically in the patient on the non-factor therapy regarding the factor 8 prophylaxis. The school participation in the schooling and the participation in sport, most of our patients on the non-factor treatment attend the school and participate in swimming, playing football, their dream to play football. Regarding the outcome, in Bayer view, there is a 54 reduction in the mobility aid. 45 of the children participate in sport today, and the Minister of Health be happy when hearing this participation in the school and the sport. 60% reduction at the missed school day after receiving factor and the biological prophylaxis, comparing the factor and the biological prophylaxis. 81% reduction on the annual bleeding rate after receiving factor, and 54 reduction in disease-related surgery. Actually, the surgery before starting prophylaxis, we have a lot of complications regarding arthropathy, regarding pseudotumor, regarding osteopenia. But after starting the era of prophylaxis, this issue of arthropathy and the complication of the bone decreasing more than 80%. Even when did a surgery regarding the pseudotumor or fracture of the bone, the use of the factor very minimal number of doses of the factor regarding the factor, or even regarding the bypassing agent for hemophilia with inhibitor. The number of the surgery decreasing, and the number of hospitalization after surgery decreasing, and the number of doses of prophylaxis decreasing after starting the era and the implementation of the prophylaxis. 95% reduction on the total hospital, as I said, more than 100 days for every patient, 7,000 days in the year for all the patients. This reduced in the hospitalization, improving the quality of life and decreasing the burden of the clinical staff and the hospital. 38% reduction in the medication cost of actual prophylaxis consumption versus on-demand therapy in both inhibitor and the non-inhibitor population, and 87% reduction in non-medication cost regarding the transportation, regarding the absence of the school, absence of the work, productivity of the patient and their family. 45% reduction in the payer burden of actual prophylaxis versus on-demand for inhibitor and the non-inhibitor patient. At the end of all these studies, study in our hospital and from the all center of hemophilia affiliated to the health organization showed that demonstrate that prophylaxis offer substantial advantage over on-demand treatment for hemophilia A, reducing the bleeding episode, surgical intervention, lower hospitalization, and improved the quality of life. So the prophylaxis is a standard of care in Egypt. What the future? What is about the future? Focusing on the real world data to publish research, digitalization for good communication between the Center for accurate registration and follow-up care. We have a lot of dreams and a lot of recommendations. At the end, at the Pharaoh built the pyramids, also the medical staff and the health insurance organization, it changed the pyramids of hemophilia care regarding the community level, the primary care, the communication between the center, the availability of treatment, updating the guideline, ending at the top of the pyramid, prophylaxis for all. Thank you very much.
Thank you. Thank you very much for that wonderful talk and sharing your experience. I think it's quite inspirational what you've managed to achieve in your country, and I think it's quite a food for thought for us in South Africa, who I think are embarking on a similar journey to yourself. So I'm going to open the floor to any discussion or any questions that there might be. Is there anyone who would like to ask a question at this point? In the meantime, I'd just like to ask, in terms of the steps forward, I think what I understand from your talk is probably the most important is to establish a very clear need or a registry of your patients.
Yes.
Presumably that initially was quite difficult to get going, but I would imagine once things have proceeded now and you see the benefits, people are submitting patients and data onto your registry.
Yes, yes. Very accurate registry is the first step to implement any prophylaxis, to calculate the budget impact and the cost effective. And the budget impact and the cost effective, how to convince the health authority that prophylaxis is saving, cost of saving money, not this year, along 5-10 years, by how many patients? What is the demographic of the patient, distribution of the patient? So utilization of the unit needed for every patient of hemophilia. You have a registry, you should to have a registry.
Yeah, no, that's extremely important. And in terms of your costs, I see you quite clearly reported that there was a decrease in costs or expenditure on patients that were on regular prophylaxis, which I think is extremely helpful to be able to talk to take to the health funders.
Yes. I think the cost of hemophilia management, not the cost of factor, but the cost of hospitalization, the cost of transportation, the cost of surgery. We have very difficult major surgery for pseudotumor and for hip transplantation, which cost millions of pounds with life, very bad quality of life. The quality of life deserve money. The quality of life deserve good management and implementation of the prophylaxis. I think the cost of the hemophilia, not including this year or implementation, is a cost saving strategy for 5 years and 10 years will be when you prevent complication, comorbidities, hospitalization, transportation, absence from the work, attendance to the hospital. A productive individual, you should to deserve and to spend money for a productive person and the productive community.
Definitely. Right. Thank you so much. I'm just making sure that there's no one that wants to ask a question. If I can just ask one more question then. If I looked at your numbers of patients and your inhibitor patients, you appear to have almost double the number of patients on imicizumab than there are inhibitor patients. What is your criteria for starting a non-inhibitor patient on imicizumab?
Starting by in the phase 2, we start inhibitor patient, negative inhibitor, life-threatening bleeding, like intracranial hemorrhage, intra-abdominal, or any patient did a surgery. This is the first. The third phase, expansion of the ages regarding the early small age with early arthropathy to prevent the complication, even in negative inhibitor patient. How to preserve this joint to improve the quality of life for non-inhibitor patient. And the second phase with the life-threatening bleeding, any patient did a surgery. And in the third phase, expansion of the age, not limited to any age, but limited to the state of arthropathy and joint status. In early arthropathy and no target joint, this is the criteria for non-factor implementation.
Jim, thank you very much. That's really, really very helpful. And again, I just want to just look in the chat if someone's asked anything. Okay, so that was just in the chat is just a reminder to complete your anonymous feedback. Are there any other questions for Dr. Shaheen while we have her online? If not, okay, thank you. I'd just like to take this opportunity to once again congratulate you on really an inspiring story. And it's something for us in South Africa to really aspire to or try and strive to achieve the same achievements that you have made. And thank you again so much for sharing your time and sharing your story.
The end, we hope to visit our country, fascinating country, and the fascinating center of hemophilia in our hospital.
Shane,
Hopefully to meet you.
Shane, thank you so much. I'd really appreciate that. So thank you very much.
Thanks very much.
Okay, thank you. And then just to the group as a whole, just a reminder of next week's topic is going to be the incidence of mutation associated with congenital thrombocytopenia. So I think that's also a very interesting talk going forward. So once again, thank you very much. And I think we'll close the meeting at this point unless there's anyone else that wants to say anything or any comments. Okay, thank you very much and enjoy the rest of your week.